In this video, we will cover the final part of Goal 2026 guidelines. This video will cover COPD exacerbations definition, diagnosis, severity, management, discharge planning, and prevention according to Goal 2026 guidelines. Definition of COPD exacerbation. A COPD exacerbation is defined as an acute event in which respiratory symptoms worsen over a short period, usually few days and up to 2 weeks. It is characterized by increased dyspnea, cough, or sputum production and may be accompanied by tachypnea or tachycardia. These episodes are often triggered by infection, air pollution, or other airway insult and are associated with increased local and systemic inflammation. In this section, we will discuss the systematic approach to diagnosing and assessing COPD exacerbations according to GOLD recommendations. Step 1. Complete clinical assessment. First step in a COPD exacerbation is a complete clinical assessment. This clinician must confirm the presence of exacerbation and simultaneously look for respiratory and non-respiratory conditions such as pneumonia, cardiac disease, and pulmonary embolism. Step 2. Symptom assessment. Next, assess the severity of dyspnea, ideally using visual analog scale. Document cough and evaluate for objective signs such as tachypnea, tachycardia, sputum characteristic, and use of accessory muscles. Step 3. Additional investigations. Additional investigations help to determine severity and etiology. If needed and available, these include pulse oximetry, arterial blood gas, inflammatory markers, and microbiological tests if indicated. Step 4. Identify underlying causes. Always search for underlying cause of exacerbation. Viral or bacterial infections are common, but environmental triggers and cardiovascular events may also be responsible. Step 5. Decide the place of care. After assessment, determine the appropriate place of setting. This depends on symptom severity, comorbidities, and patient's response to initial treatment. After confirming the diagnosis of COPD acute exacerbation, we have to classify the severity of exacerbation as mild, moderate, and severe. COPD acute exacerbation is classified to mild, moderate, and severe based on symptom burden, respiratory rate, heart rate, saturation, and inflammatory marker CRP. Mild exacerbation is defined by low symptom burden, stable vital signs, oxygen saturation above 92%, and low inflammatory marker. Moderate exacerbation requires at least 3 abnormal parameters such as increased dyspnea, tachypnea, tachycardia, hypoxemia, or elevated CRP. Blood gases may show mild hypoxemia. Severe exacerbation is defined by significant gas exchange abnormalities. These include severe hypoxemia or hypercapnic acidosis on arterial blood gas analysis. After classifying the severity, next step is identifying the cause of exacerbation using viral testing, sputum cultures, or other relevant investigations. Next section, we will deal with the COPD mimics. Several conditions can mimic COPD exacerbation. Failing to identify them leads to incorrect treatment and worse patient outcomes. This slide shows most frequent and less frequent mimics associated with COPD acute exacerbation. Most frequent mimics include bronchitis, heart failure, myocardial infarction, arrhythmias, pulmonary embolism and pneumonia. Less frequent, pneumothorax. Each mimic requires specific investigation. For example, heart failure needs BNP and echocardiography, while pulmonary embolism requires probability scoring, D-dimer, CT angiography, and pneumonia requires viral and bacterial microbiological assessment, chest X-ray or CT, lung ultrasound. And less frequent mimic is pneumothorax. It must be excluded by chest X-ray or thoracic ultrasound. Next, we will see how to decide the place of management setting for COPD acute exacerbation. This slide explains how to decide the appropriate place of management for a patient presenting with COPD acute exacerbation. Decision is based on clinical severity, comorbidities, and response to initial treatment. Once COPD exacerbation is confirmed, next step is structured assessment. Clinician must evaluate severity of symptoms, mental status, and hemodynamic stability. The presence of significant comorbidities, patient's home support system, and response to initial therapy are all crucial in deciding whether patient should be managed at ambulatory, hospitalized, or in ICU. Based on assessment, patient is directed to one of three management settings: ambulatory care, hospital admission, or intensive care. Decision depends on clinical stability, risk factors, and treatment response. Ambulatory management is suitable for patients with mild exacerbations, minimal comorbid conditions, and no signs of respiratory failure. The patient must be cooperative, stable, and have adequate support at home. Hospitalization is indicated when there are signs of respiratory failure such as tachypnea, accessory muscle use, worsening oxygenation, or hypercapnia. Patients who do not respond to initial treatment or have serious comorbidities or inadequate home support should also be admitted. Intensive care is required when patient has severe or worsening hypoxemia, needs ventilator support, or shows hemodynamic instability. Altered mental status or need for vasopressors and advanced organ support are also clear indications for ICU admissions. Now we will discuss COPD management, acute care, ventilatory support, discharge criteria, and follow-up. Management of COPD begins with assessment of symptoms, arterial blood gases, and chest X-ray. Bronchodilator therapy. Short-acting bronchodilators are the preferred choice in COPD acute exacerbation. Short-acting beta agonists with or without short-acting muscarinic antagonists are the first line. Start long-acting bronchodilators before discharge once the patient is stable. Bronchodilators can be delivered either by MDI with spacer or air-driven nebulizers. And the dosing, nebulization has to be done every hour for 2 to 3 doses and then 2 to 4 hours based on response. Bronchodilators that are not recommended are intravenous methylxanthines, theophylline, aminophylline due to their side effects. Next important pharmacological agent in treatment of COPD acute exacerbation is systemic corticosteroid. Recommended regimen is 40 mg of prednisolone or equivalent for a duration of 5 days. Oral therapy is as effective as intravenous administration. In selected patients, nebulized budesonide may be used. Systemic corticosteroids shorten the recovery time, improve the lung function and oxygenation, reduce relapse and treatment failure. Antibiotic therapy. COPD exacerbations can be viral or bacterial. Antibiotics can be given oral or IV based on severity for a duration of 5 to 7 days. Antibiotics should be given when at least two of key symptoms are present, especially when sputum purulence is one of them. They are also indicated in patients with prior positive culture or those requiring mechanical ventilation. Antibiotic choice should be gated by local resistance patterns. Common initial options include amoxicillin clavulanate, a macrolide, or a tetracycline. In selected high-risk patients, quinolone may be used. Patients with frequent exacerbations, severe obstruction, and those requiring mechanical ventilation may harbor resistant or gram-negative organisms such as Pseudomonas. In these cases, broader antibiotic coverage and sputum cultures are recommended. Oxygen and ventilatory support. COPD acute exacerbation with respiratory failure, high-flow nasal cannula or non-invasive ventilation may be considered. High-flow nasal cannula is the first mode in acute hypoxemic respiratory failure. In hypercapnic respiratory failure, non-invasive ventilation is preferred. Non-invasive ventilation improves gas exchange, reduces work of breathing, decreases need of intubation, shortens hospital stay, and improves survival. Response to HFNT or NIV is monitored using serial ABGs and pulse oximetry. Indication for high-flow oxygen therapy. High-flow oxygen therapy is indicated in patients with persistent hypoxemia, those unable to tolerate NIV, or when NIV is contraindicated. It may also be used during weaning process or to prevent reintubation. Indication for non-invasive ventilation. Non-invasive ventilation is indicated in patients with respiratory acidosis, severe dyspnea with signs of respiratory muscle fatigue, or hypoxemia that persists beyond oxygen therapy. Indications for invasive mechanical ventilation. Invasive ventilation is required when life-threatening hypoxemia persists despite non-invasive support, or when patient cannot tolerate HFNT or NIV. Other indications include cardiac or respiratory arrest, reduced consciousness, aspiration, inability to clear secretions, severe instability or arrhythmias. Supportive measures to be followed in all COPD exacerbation include monitoring fluid balance and diuretics if needed, providing thromboembolism prophylaxis with heparin or low molecular weight heparin, and actively treating the associated conditions such as heart failure, arrhythmias, or pulmonary embolism. Discharge criteria. Before discharge, review all clinical data, optimize therapy, reassess inhaler technique, evaluate oxygen needs, address comorbidities, provide a management plan, and arrange for follow-up. Early follow-up within 1 to 4 weeks. At 1 to 4 weeks, evaluate patient's ability to cope at home, review treatment understanding, reassess inhaler technique, evaluate oxygen needs, assess activity levels, consider pulmonary rehabilitations, document symptoms, and check comorbidities. Late follow-up. At 12 to 16 weeks, reassess functional status, treatment adherence, inhaler technique, and oxygen needs, perform spirometry, document FEV1, document symptoms, and evaluate comorbidities. Interventions that reduce exacerbations. Multiple interventions have been shown to reduce frequency of COPD exacerbations. These include longer-acting bronchodilators such as LABAs and LAMAs, as well as triple therapy with inhaled glucocorticoids. Non-steroidal anti-inflammatory options includes roflumilast and biologicals in selected cases. Anti-infective strategies such as vaccination and long-term macrolides are also effective. Mucoregulators may reduce exacerbations in selected patients. In addition, non-pharmacological interventions such as smoking cessation, pulmonary rehabilitation, lung volume reduction, vitamin D in selected individuals, and infection prevention measures play an important role in reducing exacerbation risk. In summary, diagnose exacerbations clinically and rule out mimics. Classify severity objectively. Treat with bronchodilators, steroids, and antibiotics appropriately. Use ventilatory support for hypoxemia or hypercapnic respiratory acidosis. Ensure proper discharge planning and follow-up, and also focus on preventing future exacerbation.